Imagine for a second that you have incredibly flexible joints. Like you can bend your thumb all the way back to your wrist, or maybe you can contort your body into these impossible pretzel-like shapes.
Right.
And it is a fantastic party trick, you know? People are totally amazed. But what they don't see, what you are hiding from them, is that this exact same flexibility is causing you chronic, debilitating, and completely hidden pain in your pelvic floor.
Yeah, it's a huge issue.
Welcome to the deep dive. I mean, you wouldn't normally think party trick flexibility and the booming multi-million-dollar vaginal rejuvenation industry have anything in common, but when they collide, the results are really shocking.
It really is. It's a collision of human biology and commercial medicine that creates a completely unique and honestly often dangerous situation.
Mm.
We're looking at a very specific patient population trying to navigate this landscape of heavily marketed elective cosmetic procedures.
And we have pulled together a massive, just a really diverse stack of sources for you to look at today. We are cross-referencing medical case reports, clinical guidelines from NICE and the NHS, safety communications directly from the FDA, and we're kind of holding all of that up against the glossy promotional materials from these intimate wellness clinics.
Quite a contrast, to say the least.
It really is. So our mission for this deep dive is to answer one core question. Should hypermobile patients avoid certain vaginal tightening procedures? Okay, let's unpack this. Because to get to the bottom of that, we need to figure out the actual science of hypermobile tissues and then look at the hard data of what happens when those incredibly fragile tissues meet, cosmetic lasers, radiofrequency devices, and scalpels.
Yeah, and to even begin evaluating why these treatments might fail or cause serious harm, we first have to map out the biological reality that hypermobile patients live with every single day. Like, why are they seeking out these intimate tightening procedures in the first place,
Well, nobody is just waking up and deciding to have a high-powered laser pointed at their most sensitive anatomy just for the fun of it.
Exactly.
There is a profound level of physical distress driving this. The conditions we are talking about are Ehlers-Danlos syndrome, or EDS, and hypermobility spectrum disorder, HSD. These are genetic connective tissue disorders. But what is actually going wrong inside the body to cause that?
It all comes down to collagen.
Okay.
Collagen is essentially the scaffolding that holds the entire human body together. I mean, what gives our skin its elasticity, it forms our ligaments and tendons, and it provides structural integrity to our organs and our blood vessels.
So it's basically everywhere.
Everywhere. And in someone with EDS or HSD, a genetic mutation means the body is producing collagen that is structurally flawed. The raw material itself is just, well, it's defective, it's too stretchy, and it lacks strength.
I always thought these conditions were considered incredibly rare, like the kind of thing you only read about in a dusty medical textbook as some, I don't know, exotic anomaly.
Right, yeah. And so did the medical establishment for a really long time. But the latest data paints a very different picture. A major population study out of Wales recently looked at health records to track diagnosed cases.
How many records are we talking about here?
Almost 1.7 million.
Wow. Over 1 million people. And what did they find in all that data?
They put the diagnosed prevalence of hypermobility syndromes at roughly 1 in 500.
1 in 500. I mean, that means almost everyone knows someone dealing with this, whether it's diagnosed or not.
Exactly.
And because collagen is literally everywhere in the body, the symptoms pop up everywhere. But for this deep dive, our sources focus specifically on the pelvis, and the details are just staggering. We are talking about women experiencing severe pelvic organ prolapse.
Yeah, that's where organs like the bladder, the bowel, or the uterus actually drop out of their normal position because the suspensory ligaments holding them up are made of that same weak, stretchy collagen. Gravity simply wins, basically.
And this is happening earlier in life for them, completely independent of the usual risk factors like traumatic childbirth or menopause, right?
Yeah, age and childbirth aren't always the main drivers here.
Plus, alongside the prolapse, the data shows incredibly high rates of stress, urinary incontinence.
Right, a large urogynecological survey we looked at reported stress incontinence in roughly 50% of women with hypermobile EDS.
Wow.
But perhaps the most distressing symptom, and unfortunately the one most often dismissed by doctors, is the high rate of dyspareunia.
Which is the medical term for painful sex.
Yes, exactly. That same international survey reported dyspareunia in 64% of respondents. And it's not just discomfort, They report recurrent, spontaneous vaginal skin splitting and tearing.
Oh my God.
The tissue is genuinely just that fragile. It breaks under normal friction.
Which sets up something that completely blew my mind when reading through the sources. It's called the hypermobility paradox. This is the idea that having loose, hypermobile joints actually leads to intensely tight, cramped muscles.
Right. It seems counterintuitive.
It totally does. But think about the hypermobile pelvic floor, like a massive suspension bridge. The ligaments are supposed to be the thick main cables holding the whole structure up. But in an EDS patient, those cables are loose. They are faulty and stretchy.
Yeah.
So the central nervous system panics. It forces the rigid support beams, like the muscles themselves, to absorb all of that kinetic shock. The muscles have to work overtime to hold the bridge together until they literally seize up and fracture.
What's fascinating here is how that exact paradox makes diagnosis and treatment incredibly tricky. Just picture a patient going to a doctor complaining of pelvic heaviness, prolapse, or a feeling of laxity and looseness in the vagina.
Right, they feel loose.
Right. And the standard medical advice for a quote-unquote loose pelvic floor is to prescribe Kegel exercises to strengthen and tighten up the muscles.
But wait, if the bridge is already seizing up, aren't those muscles already tight?
That is exactly the problem. In a hypermobile patient, those muscles are hypertonic.
Let's define that really quick. Hypertonic just means they have too much tone.
Yes, they are locked in a state of sustained, low-grade guarding. They basically never fully relax.
They are clenched like a fist, desperately trying to hold the pelvis together against gravity.
Precisely. So, prescribing strengthening exercises to an already clenched, totally exhausted muscle group often just makes the pain and dysfunction significantly worse.
Oh, man.
Treating the perceived looseness with standard Kegels almost never helps because the body is tightly holding on for a reason.
So put yourself in the patient's shoes. You are in pain, experiencing prolapse, maybe dealing with incontinence, and a traditional physical therapy is failing you. You are desperate for a solution. And that brings us to the widely marketed cure: energy-based devices, or EBDs, and the broader world of vaginal tightening.
This is where we see the intense intersection of genuine, untreated patient distress and a booming commercial market. Private, intimate wellness clinics are stepping into the void, offering non-surgical options as a cure-all.
What kind of options?
We are talking about CO2 lasers, erbium-Y lasers, and radiofrequency devices.
Looking at the promotional materials from these clinics is just a wild ride. The brochures make it sound like you're popping in for a quick latte, but for your pelvic floor.
Yeah, they really do.
They're marketed as 5-minute outpatient procedures. Walk in, get lasered, walk out. Minimal downtime. They feature glowing testimonials broadcast on major networks like the BBC and ITV. And the clinics claim incredibly high success rates, like citing retrospective studies that point to upwards of 84 to 90% improvement in treating laxity, vaginal dryness, and mild prolapse.
It sounds incredible on paper.
It sounds like a miracle. But how are these machines actually supposed to work? I mean, structurally.
Let's break down the mechanics. Whether a clinic is using a CO2 laser, an erbium-Y laser, or a radiofrequency device, they all share a common goal: causing a controlled thermal injury to the vaginal mucosa.
Thermal injury, meaning they are intentionally burning the tissue inside the vagina.
Yes, but in very specific ways. A CO2 laser penetrates deeply, vaporizing tissue and generating a lot of heat. An erbium-Y laser is highly absorbed by water in the cells, so it stays more superficial, causing what we call microablative burns, literally vaporizing microscopic pinpricks of tissue.
Wow, okay. And the radiofrequency?
Radiofrequency, on the other hand, doesn't vaporize tissue. It uses electrical currents to heat the deeper layers from underneath without breaking the surface.
Okay, so whether we are talking about burning tiny holes or cooking the tissue from below, what is the biological goal here? Why injure the body to heal it?
The medical term for the goal is neocollagenesis. Neo meaning new, collagenesis meaning making collagen.
Right.
The theory is that by intentionally injuring the tissue, you trigger the body's natural inflammatory repair mechanisms. You basically wake up the fibroblasts.
Fibroblasts, are those the actual cells inside the body that act like little collagen factories?
That's a perfect way to describe them, yeah. The heat stimulates the fibroblasts to rush to the site of the injury and produce brand new collagen and elastin fibers, thereby tightening, thickening, and rejuvenating the vaginal walls.
But hold on. Wait, if an EDS patient's fundamental genetic issue is that their collagen factories only have the blueprints to produce faulty collagen, how does using a laser to stimulate the production of more of that same flawed collagen actually help?
That is the million-dollar question.
Aren't we just building a thicker wall using the exact same crumbling bricks?
If we connect this to the bigger picture, you've just hit on the brilliant physiological contradiction at the heart of this entire issue. You're exactly right. You are forcing the body to lay down more bricks, but the factory is still printing defective ones.
It just doesn't make sense.
No, you induce trauma to force a healing response in a body where the healing response itself is genetically compromised. The result isn't a strong, resilient wall. You get a thicker wall, yes, but it is totally rigid and functionally useless.
Here's where it gets really interesting and honestly quite harrowing to read about.
Mhm.
When we step out of the glossy clinic brochures and look at the actual medical case studies, like what happens when surgeons look at the aftermath of these lasers on hypermobile tissue, it paints a horrific picture.
It really does. The sources detail several specific case reports of women with hypermobility who underwent laser vaginal tightening and subsequently required reconstructive surgery because their symptoms either completely failed to improve or worsened dramatically.
Let's talk about those surgical findings,
Yeah.
because they answer my question about the crumbling bricks. When surgeons went in with a scalpel to try and repair the damage on women who had previously received laser treatments, they did not find healthy, plump, rejuvenated tissue.
No, not at all.
In one case, the vaginal mucosa was described as rigid and heavily scarred, making the surgical dissection incredibly difficult.
And in another case, the surgeon noted the tissue was paper-thin, friable, with a complete loss of rugae.
Rugae being the normal sort of accordion-like folds of the vagina that allow it to stretch.
Correct. The laser had basically obliterated them. The surgeon literally described the vaginal wall as feeling like wet tissue paper, noting that it was tearing and disintegrating just upon handling it with their instruments.
It's just disintegrating. And we see even more severe adverse events formally documented in the clinical guidelines from NICE. That's the National Institute for Health and Care Excellence in the UK.
Right.
They highlighted a deeply upsetting case of a 65-year-old postmenopausal woman who underwent 3 separate laser treatments. And when she attempted intercourse a few weeks after her final session, she experienced heavy vaginal bleeding from severe lacerations.
And the really tragic part is that the damage was permanent. When she presented to doctors months later, she reported severe chronic pain, extreme dryness, and a complete inability to engage in penetrative intercourse at all.
Wow.
The laser-induced fibrosis, the thick, rigid scarring, was so extreme that her vaginal canal had foreshortened to just 2.5 centimeters in length.
Just a single inch. That is terrifying. Another case in the MICE guidelines described a 68-year-old woman who, after a standard laser treatment, developed a thick, crescent-shaped fibrous band right in the middle of her vagina.
Yeah, they create a stricture.
Right. It essentially created a partial obstruction of the canal, accompanied by pale, frail, inelastic tissues. It's just incredibly heartbreaking. You have patients actively seeking out an elective procedure specifically to improve their intimate wellness and sexual function, and it ironically results in massive structural damage that makes penetrative intercourse physically impossible.
Exactly. The lasers trigger a chaotic, completely unpredictable scarring response instead of a rejuvenating one.
So if the laser is literally burning bad tissue to make more bad tissue, what about ditching the energy devices and just using a scalpel? Like traditional surgery, what happens when an EDS patient undergoes a standard vaginoplasty to tighten the canal or a labiaplasty?
Well, traditional surgery carries an entirely different set of severe mechanical failures for this population because EDS skin inherently lacks normal tensile strength.
Tensile strength meaning like how much you can stretch or pull on the skin before it snaps.
Precisely. Because they lack that strength, standard surgical protocols simply fail. Surgeons report that sutures pull right out of the fragile skin. It has been described in the surgical literature as acting like a cheese wire pulling through wet paper.
Oh, God. That visual is awful.
It is. The thread just slices through the tissue instead of holding it together.
Which means wound dehiscence. Like the spontaneous bursting open of the surgical incision, that has to be a massive risk.
Oh, it is far more common. Furthermore, there are incredibly high risks of massive hematomas. A hematoma is a severe pooling of blood under the skin.
Why does that happen more frequently in EDS patients?
Because the walls of our blood vessels are also made of collagen.
Ah, of course.
So in hypermobile patients, those vessels are weak and stretchy. During surgery, they rupture much more easily, leading to internal bleeding. And even if you avoid a hematoma and the wound eventually manages to close, the resulting scar tissue in an EDS patient is often hypertrophic.
Meaning it's excessively thick and raised.
Yes, and completely lacks elasticity.
Hmm.
So it is highly prone to tearing all over again during any future intercourse.
The fundamental assumption of both the laser clinic protocols and standard surgical protocols is that the patient sitting in the chair possesses a normal, predictable, inflammatory, and fibrotic healing response. but the EDS patient simply does not.
That is the absolute core of the issue. The treatments rely on a biological mechanism the patient literally doesn't have.
So we have established that the risks are astronomical. This brings us to how patients and the medical system at large are navigating this massive clash between what the private clinics are marketing and the physical reality of the patients.
Yeah, and if we look at the regulatory landscape across our sources, it is currently a space of intense friction. On one hand, you have the FDA in the United States issuing a very clear, very stark safety communication.
What are they saying?
They are explicitly warning against the use of energy-based devices for vaginal rejuvenation due to the risk of exactly the adverse events we just covered: burns, unpredictable scarring, and chronic, unrelenting pain.
And over in the UK, you have regional NHS trusts like Cheshire and Merseyside implementing strict clinical commissioning policies. These are the rules that dictate what the National Health Service will actually pay for.
Right.
They severely restrict procedures like labiaplasty and vaginoplasty, categorizing them strictly as cosmetic. They are not routinely commissioned unless a patient meets very specific, severe criteria, like massive trauma from childbirth or major congenital abnormalities. Additionally, the Royal College of Obstetricians and Gynecologists is calling for a total sweeping ban on hymenoplasty, stating there is absolutely zero medical justification for it.
Yet, contrasted against those stark warnings from regulatory bodies, you have the independent intimate wellness clinics. Many of these clinics, backed by some independent studies, firmly maintain that these treatments are perfectly safe and highly effective.
For everyone.
Well, for the general non-hypermobile population, they often are. They point to retrospective analyses showing that new collagen deposition does indeed resolve mild stress incontinence and improve pelvic floor tone for many women without connective tissue disorders.
But that creates a terrifying, confusing maze for the hypermobile patient. If the marketing brochures say it works wonderfully, but their underlying biology dictates it's a hazard, what are their actual safe alternatives for getting relief from these very real symptoms?
The medical literature does outline a few very specific, tailored alternatives that avoid the risks of dermal injury. First and foremost is specialized pelvic floor physical therapy. But, and this is crucial, it has to be physical therapy heavily focused on down training.
Down training, like the opposite of lifting weights.
Kind of. Remember the suspension bridge analogy? The therapist must first teach those hypertonic, constantly clenched muscles how to fully relax and let go. They have to calm the nervous system down before attempting any kind of strengthening.
That makes total sense.
It is about restoring neuromuscular coordination, not just forcefully repping out Kegels. Biofeedback, using sensors to help the patient actually visualize their muscle tension on a screen, can be highly effective for this.
And what if surgery is absolutely unavoidable, say for severe prolapse?
If surgery is necessary, it requires a specialized surgical team intimately familiar with the nuances of EDS. This means creating tailored anesthesia protocols to protect the hypermobile cervical spine during intubation.
Because the ligaments in the neck are loose, too.
Exactly. It means using non-reactive sutures, employing very specific layered suturing techniques to distribute tension and avoid the cheese wire effect, and leaving those sutures in place for much longer to account for delayed wound healing. This raises an important question regarding medical advocacy. In a modern medical system where hypermobile women are routinely dismissed by doctors as being, quote-unquote, just a bit bendy, how do they successfully advocate for themselves when seeking relief from genuinely debilitating symptoms, while simultaneously protecting themselves from heavily marketed procedures that could cause them permanent harm?
It is a massive, unfair burden. What stands out to you about this? Think about the weight placed on a patient with a rare, or at least rarely understood, condition. They aren't just managing their daily pain. They are frequently forced into the position of having to educate their own doctors and surgeons about the risks of a procedure that the doctor themselves is proudly offering.
Yeah, they have to be the smartest medical expert in the room just to stay safe.
Exactly.
It highlights a critical, glaring gap in standard medical education regarding connective tissue disorders, especially when contrasted against the rapid, aggressive commercialization of aesthetic medicine.
So, what does this all mean? If we distill all of these diverse sources, all of these medical case reports, FDA warnings, and marketing claims down to a single core takeaway, it is this. While vaginal tightening procedures, whether executed by a CO2 laser, a radiofrequency device, or a surgeon's scalpel, might offer genuine relief and rejuvenation for the general public, The hypermobile patient is playing a totally different biological game.
A very dangerous game.
Yes, for someone with Ehlers-Danlos syndrome, the unique fragility and faulty collagen of their connective tissue turns rejuvenation into a high-risk gamble. It is a gamble that can lead to severe scarring, permanent tissue degradation, and even worse pelvic dysfunction than they started with.
The intention behind the patient seeking treatment is incredibly valid and understandable, but the underlying mechanism of these specific cosmetic treatments is fundamentally incompatible with their genetic makeup.
I want to leave you with a final thought to mull over, something to explore on your own that builds on everything we have just unpacked. We have seen the devastating, unpredictable fibrosis and scarring that lasers and radiofrequency devices can cause in the pelvic region of an EDS patient, specifically because of how those devices interact with faulty collagen.
Right.
But the rejuvenation industry goes far beyond pelvic health. What hidden long-term risks might these exact same hypermobile patients be facing right now from the massive booming industry of facial lasers, cosmetic microneedling, and non-surgical body sculpting?
That is a fascinating point.
Those treatments are being aggressively marketed on every street corner, and they rely on the exact same underlying biological mechanism, controlled thermal injury and neocollagenesis. If the bricks are crumbling in the pelvis, they are crumbling in the face and the body too.
It is a profound question about the systemic, full-body nature of connective tissue disorders when they come face-to-face with modern aesthetic technology.
Thank you for joining us for this deep dive into the sources. We hope it gave you a new lens on how to look at the intersection of our biology and the heavily marketed treatments we are sold. Keep asking questions, keep reading the fine print, and remember, what looks like a simple party trick might just be holding up a very delicate, highly complicated bridge.